All right, so this is actually a continuation of the same concept. Last week we ended with TBI, post-op craniotomy. We discussed the routine medications, correct? What are those medications again? Routinely given for post-op for any craniotomy patient, whether the craniotomy was done to remove a tumor or let's say to evacuate hematoma. What were those medications again? Standard medications that every patient will be receiving.
Glucocorticoids.
Okay, that's one.
Anti-epileptic.
Okay, anti-seizure medications.
Also prevention drugs like your
API or H2 receptor blockers. What else?
Antibiotics.
Very good. And whatever else is said. All right, so let's go now to a stroke patient. So this is just a different form or a different cause of increased ICP. There are two types of strokes. Before that, let's do TIA first. Now, if you remember the concept of atherosclerosis, which is the same risk factor here for stroke, they share risk factors for with patients who have heart disease, particularly acute coronary syndrome or coronary artery disease, and also with patients in chapter 36, which was peripheral artery disease, hypertension. So it's the same thing. Now, it just so happened that there was the atherosclerosis. Can you see the whiteboard? So the atherosclerosis is occurring in a different vessel. You can see the whiteboard, right?
Yes.
So let's say this is a normal vessel, and then now you have a vessel with a plaque. So as the plaque progresses, so this is now the size of the plaque versus this one, and this is normal. So it's just a matter of which artery are we talking about here? So if this artery is a coronary artery, then you have acute coronary syndrome. So there's chest pain. If this is a peripheral artery, such as a, I don't know, femoral, iliac, popliteal, etc. Whichever artery this is, what do you call that pain again? Experienced by patients with PAD, you know, when they walk and then they stop. This occurs at stage 2 peripheral artery disease. What do you call that pain again? That reproducible pain that when they walk, it causes pain, they stop, and then resting relieves it, and then they go out and walk again, and then the pain returns. What do you call that again? From chapter 36?
Is it consolidated? Consolidate?
No. What do you call a symptom? It's found in stage 2. It begins in stage 2. So there is pain on exertion, on walking. And then when it goes stage 3, as the plaque progresses,
Wasn't that called claudation?
Claudication, very good. So we call it intermittent claudication. And then now here, what if it occurs in a cerebral artery? This is now a TIA or stroke, depending on how severe is the atherosclerotic plaque. So as you can see, it's really the same pathophysiology. It's all the risk factors here are the same. You have an atherosclerotic plaque which can form in any artery. So let's say in a coronary artery, if this thing forms in a coronary artery. So this one would be, let's say, chronic stable angina. Okay, chronic stable angina, because it's still small, meaning in all three examples, as the oxygen demand increases, so let's say in coronary artery disease. So if you have chronic stable angina, so let's say you're shoveling snow, you're walking up the stairs, you're running a marathon, what happens to your oxygen demand?
You need more increases.
All right, because your muscles are burning more oxygen, so the demand is increasing. Even your the heart muscles are also consuming more oxygen because they have to pump faster, pump stronger in order to supply the increased oxygen demand by the skeletal muscles. Now, will there be enough supply of that oxygen if there is now narrowing of the artery? Plus, you know that exertion will cause some coronary spasm as well. Because the more you cause stress on the heart, so there's a chance that this could go into spasm. So that will cause narrowing of the artery. So therefore, the pain here in all these conditions here, the pain, the claudication, the chest pain here, and although you won't have brain pain, but all of these are caused by ischemia. Meaning there is less blood flow to the organ. So as this increases though, so a TIA may be if the plaque is this bad. However, if this plaque progresses, gets worse, the patient doesn't comply with the therapy, doesn't take the statin drugs, or does not comply with the low cholesterol diet, doesn't comply with the exercise, then of course it will just be a matter of time until it becomes a stroke. Because now, so which is also the same here, if the chronic stable angina progresses, becomes like this, the coronary artery becomes, the plaque becomes this bad now, so it won't be just stable angina, it will now be unstable angina. It could be STEMI, it could be non-STEMI. All right, you understand the concept? So later when we go to chapter 38, it will be really the same story. The same story as in chapter 36, here 36, 38, the same story. And then now we have 45 when we talk about TIA or strokes. So let's start with the TIA. So TIA is only a brief interruption of cerebral blood flow, meaning it's not permanent. So this may last for a few minutes, a few seconds to a few minutes to several minutes to up to less than an hour. The key here is the symptoms resolve. However, when the patient comes in with these symptoms, it's hard to tell whether or not it's a stroke or a TIA because the symptoms are really the same. Chart 45-1 are the key features of a TIA, which coincidentally are actually the same symptoms of a stroke. The only difference is all these changes here, the eye changes, blurred vision, double vision, blindness in one eye, tunnel vision, or this tunnel vision is also called, we'll look at it later in the chapter, this is also called hemianopsia. I'll explain later. There's a figure that will explain tunnel vision. And then there's weakness, which will be manifested by either drooping of the eyelids or facial droop, arm or leg drift, for instance. Ataxia, patients will have a disturbed gait. There's numbness, meaning loss of sensation on one side of the body. Could be the left side or the right side. There's vertigo also, meaning spinning, or motion sickness sensation. And then you have aphasia, difficulty speaking, and dysarthria. The key here is the symptoms resolve within 24 hours. Okay, so therefore, it's not a stroke. The patient was lucky, it did not end up in an infarction. So an infarction is actual death of tissue. So we call it the same in an MI. So it's called a myocardial infarction, meaning some part of your myocardium died, or in this case of a cerebral infarction or stroke, parts of your brain died. Or in the case of a pulmonary infarction also, so parts of your lung also died. Although pulmonary infarction is very rare, I'll explain later when we get to chapter 32. Questions so far with the TIA? Again, the key here is these symptoms resolve, but again, when the patient presents to the ER or no, at home, for instance, you wouldn't say, oh, this is just a TIA. There's no way you can tell them apart. The patient has the exact same symptoms as someone who is having a stroke. This one's complete though, chart 45-1. We'll have 3 different parts wherein we're reviewing signs and symptoms of stroke. This is the first part. So let's do prevention first. So if the patient was diagnosed with a TIA, so they're lucky. They did not have any permanent damage to any part of the cerebral tissue. So therefore, once a TIA is diagnosed, then the patient will be encouraged to do the following. So it will be about lifestyle modifications or risk factor modification. So one of the risk factors are blood pressure, hypertension, high blood pressure that is. You'll be put on aspirin or clopidogrel, which is Plavix. The doctor makes a decision whether it's one or the other or both. Controlling diabetes, this is again another risk factor for all 3, PAD, ACS, and stroke. And then of course, promoting lifestyle changes, stop smoking, eating healthier, moderate alcohol, and exercise, regular exercise. A stroke is now different. And obviously this is a medical emergency, and this is one of the most commonly occurring problems in the United States, actually worldwide. There are 2 general types. We have ischemic and hemorrhagic. Ischemic has 2 further subcategories. Ischemic stroke can be thrombotic or embolic. Thrombotic meaning the problem or the clot or the atherosclerosis occurred in a cerebral artery. In embolic stroke, which is still ischemic, the clot here that caused the obstruction may come from elsewhere, not necessarily formed within a cerebral artery, unlike in thrombotic stroke. This one is usually cardiac in nature, meaning you had a problem elsewhere. Let's say, like I said, again, it's usually cardiac. You have AFib, heart failure, a valve problem, or a flutter, for instance, or any other condition that causes a clot to form inside the heart, or in rare cases, a DVT. A DVT usually causes a PE, a pulmonary embolus, rather than a stroke. But in rare cases, it may make its way up to the brain as well. Hemorrhagic stroke are caused by 3 possible risk factors. One is an aneurysm. Aneurysm is in chapter 36. ABM. Aneurysms are weakened areas of an artery. However, it's only affecting 2 layers of the vessel though. The 3rd layer, which is the tunica externa, is intact, meaning the vessel isn't broken. The vessel was just weakened due to usually number 1 problems are atherosclerosis and hypertension. Atherosclerosis, of course, the plaque forms in, so if this is the plaque that I'm talking about, if you look at it in cross-section of a vessel, the plaque actually forms here. And this is the middle, and this is now the innermost layer. So there are 3 layers of a vessel. So let's say the outermost layer is number 3, and this one here is number 2, and this is number 1. Number 1 would be the innermost layer. The plaque forms between layers 1 and 2. So it's not above layer number 1. So if this plaque forms here, of course, it will weaken the integrity of this vessel. So in this artery, for instance, so you can have more than one. So you have one plaque formation there, you have another one here. Of course, this will weaken the vessel. Plus, if you add very high blood pressure there, constantly flowing through this already weakened wall, of course, this will eventually dilate, causing an aneurysm. An AVM is different. So an AVM is an abnormal connection between an artery and a vein. Are arteries and veins normally connected? Did you say yes?
Yeah.
They come to a point where in the capillary beds.
Okay, so no, they're not. So an artery becomes an arteriole, gets smaller and smaller, same thing here, and they meet at the capillary network. So they get smaller and smaller, becomes arterioles, here also called venules, and they meet at this capillary network. So that's how they're joined together. So you'll never see an artery and a vein connected, except maybe last semester you talked about an AVF, right? In hemodialysis in chapter 68. So the doctor constructed a vessel between, an artificial vessel between a artery and a vein. So we call this now a fistula. Fistula is an abnormal connection. So we surgically created this one. This is fine because we needed it. However, an AVM is usually congenital. You're born with it and they don't cause problems. So you have a connection like this between an artery and a vein. They're joined together. And if you remember the shape of the AV fistula, you saw the pictures on chapter 68. Was it beautiful? Do AV fistulas look nice?
Yes.
How are they nice?
No, they're not.
Well, maybe for a dialysis nurse, yes. Yeah, it looks beautiful because you can, the bigger it is, the easier it is to poke and stick. But for the patient, of course, that's ugly because this will imagine something poking out of your skin, which is like a piece of bowel, for instance, or a tortuous vessel. Okay, so it's ugly looking. This is also what will happen in an AVM. Now, in a AVM, as it's developing, as long as the patient doesn't develop hypertension or any other cardiovascular disease, they're fine. I mean, they won't cause problems. However, if you add hypertension now to a patient with AVM, then the connection, let's say this is an artery and this is a vein. Of course, the vein is not built like an artery. Arteries are stronger because they're made to withstand higher pressures from the blood coming out of the heart, whereas the veins are passively returning blood back to the heart. So if you subject a vein to the same pressures of an artery, of course, this one will grow bigger. And since they're not made the same way as an artery, an ABM will eventually rupture. And it's just a matter of where is the ABM. So in the case of an ABM occurring inside the cerebral circulation, then that can rupture, then becomes a hemorrhagic stroke. ABMs can also occur in the mesentery inside the GI tract. The same way, it may rupture, causing GI bleeding. And then, of course, the third risk factor here is the cause is hypertension. That's why if you remember also in chapter 36, when we talked about malignant hypertension, or I forgot what chapter spinal cord injury was that 44 or
42, I think.
something like that, 44 or 42. If you remember from last semester also, autonomic dysreflexia. You remember that term?
Yeah.
Yeah, it was a complication after spinal cord injury, right? Occurs years after the injury, not necessarily during the acute episode. That was the number one characteristic there was also severe hypertension, correct? And in the interventions there, we watched the patient for any neurologic deficits because because the blood pressure there was 220 or higher, correct? So that might places the patient at really high risk for hemorrhagic stroke. So if we compare these three side by side, table 45-1. So based on the formation, so let's say in a thrombotic stroke, the thrombus again, or the atherosclerosis, formed within a cerebral artery. So that's why your onset is more gradual, and usually these things have a TIA. They have a warning sign. So before the patient gets a stroke, they will have one or multiple episodes of a TIA because, again, the thrombus occurred in a cerebral artery. Embolic, which is usually cardiac in nature, meaning you had a AFib, like I mentioned earlier, AFib, a flutter, you have a valve disorder, you have heart failure, or you throw any other fatal dysrhythmia wherein the heart isn't really contracting effectively, causing blood to pool inside one or more heart chambers. Then, of course, they will throw a clot. Clot forms there, and then clot ends up in the cerebral artery. That's why your onset here is sudden. Okay, you're just walking around with no problem, and then suddenly you develop a stroke. This one is more slow, usually precipitated by a TIA. There's also a TIA, meaning a TIA is also possible in embolic, depending on the size of the clot. If the clot is small enough, then it will only cause temporary obstruction of a cerebral artery. And you know already from last week when the cerebral perfusion pressure drops, meaning if this clot, tiny clot, for instance, causes decreased blood flow or ischemia to the cerebral artery, which will of course cause inflammation and injury to one or more parts of the brain. Remember autoregulation, the brain will automatically raise the blood pressure. So that high blood pressure may dislodge that tiny clot and then restore blood flow. Whereas if you look at the hemorrhagic stroke, it's also sudden because of course this is caused by a rupture of a aneurysm, a AVM, or just caused by severe hypertension. So the rupture of the vessel is sudden. All of these, though, will have increased ICP. Between the three, of course, it will be hemorrhagic that will cause a rapid increase in ICP because of the presence of the blood. And of course, your CSF on examination, this one may be normal. This one will be normal also, but this one definitely will be very bloody. So the increase in ICP here triggers a seizure in hemorrhagic stroke, not so in thrombotic or embolic stroke. However, if the patient doesn't receive treatment here, of course, there will be increased ICP eventually because as the brain cells die, there will be inflammation and edema around the dead parts of the brain, which will still increase the volume of the brain tissue, causing increase in ICP eventually, but not right away. This one's definitely the same as in traumatic brain injury. Any question on this one? I won't read the whole thing. Okay, you read the the rest of the table. And I already discussed that, so please read this paragraph and this paragraph also. Let's go to prevention. So we promote health, so health promotion and maintenance. We prevent stroke first. So we already looked at it earlier under TIA. So these measures right here. Okay, so these are your prevention. Now, since all of these are caused, look at it, it's high blood pressure. So what will be the patient's diet, for instance? Is it different from the DASH diet we talked about in chapter 36?
No.
All right, exactly the same. So we put the patient because the patient is likely to have a stroke because of the risk factors. So we put them on antiplatelets now to prevent clots from forming? All right, so that's why we have the aspirin or clopidogrel there. And then diabetes, of course, and stop smoking and eating healthy and regular exercise. So that's part of your health promotion right here. Here are the modifiable as well as non-modifiable risk factors, which are, no, this chart only talks about the modifiable risk factors of stroke. If you remember OCP, where did you see this also? How does OCP cause a stroke? Especially when paired with smoking. Say a female patient takes oral contraceptives and also smokes, that will be a double whammy now. You have two risk factors for stroke. How do pills, birth control pills, cause a stroke?
If you smoke with them, they increase the risk for blood clots, right?
Well, let's say I'm not smoking. I just take OCPs. How does how does estrogen cause a stroke?
Doesn't it make the blood more likely to clot? Like it increases the level of clotting factors, maybe?
Remember, this was also mentioned in chapter 36 under DVTs. Risk factors for DVT. It was also the same. Smoking and OCP. So for those who take OCPs, or let's say you've heard or you know somebody who's taking it, what do they look like? What are their common complaints or side effects of taking OCPs? What do
Weight gain. Weight gain.
All right, weight gain. So how does weight gain precipitate clot formation? So as blood glucose increase, or let's say increased blood volume, which will contribute to the weight gain, actually decreases venous return, correct?
Yes, weight gain actually increases the fat increase in the artery. So that's how it blocks the
So there's
blood.
several ways OCPs can cause blood clots. It begins with increased blood volume. Of course, increased blood volume will cause venostasis, especially in the periphery, and then that will now cause the formation of blood clots. And that clot, again, can travel anywhere it wants. So let's go straight to, because the signs and symptoms we already talked about in chart 45-1 under TIA. But a crucial question upon admission will be, when did the symptoms begin? A common concept in perfusion is, which will be the same in ACS also when we go to chapter 38, especially here in stroke, is time is tissue. So we need to know, when did the symptoms occur, because that was when the patient started having decreased blood flow to the brain. Right, so we need to know how long has it been, when did the symptoms start, because that will determine our treatment. Let's go to scoring. I won't test NIH stroke scale. I never did. The reason is we're not expected to be working in a neuro unit. So all these years that I've taught fifth semester, I've never taught this. Not only is it a specialty area or more focused on stroke, look at how long this is. So this would be ABC, so that means there are 11. So this is 14 total. This is 11 plus 2, yeah, 13 actually. Yeah, 13. There are 13 categories here versus Glasgow Coma scoring, which is shorter. There we only have 3. All right, so for our purpose, we won't test table 45-2. We will, however, use the Glasgow Coma scale after the break. So let's meet again at 1:55. All right, it's time for a break. Any questions before we go?